Welcome to this review of the pharmacotherapy of ADHD. I am Dr. Amer Cann. Let's get started. Our learning objectives for this review include discussing the etiology and aberrant signaling that we have found in the development of ADHD. We will distinguish ADHD from other neuropsychiatric disorders. We'll compare and contrast the different medications that we use in managing ADHD. We'll evaluate those pharmacotherapy choices given the adverse events, contraindications, and drug-drug interactions associated with those medications. And then, given some patient cases, we will develop a therapy plan. Boys are twice as likely to be diagnosed with ADHD than girls. I don't know that boys actually do have ADHD more often than girls, but they are more likely to be diagnosed. It affects about 6 to 9% of kids in general and about 4% of adults. In Kentucky, where I practice, we rank second in percentage of children that are treated with ADHD medications. That's at 10.1%. Louisiana is the only state that beats us at 10.4% of kids. And ADHD treatment rates are rising, I think because we're getting better at diagnosing. ADHD has a lot of effects in different areas of the brain. At the prefrontal cortex, it affects how we make decisions and our spontaneity, impulsivity. At the basal ganglia, we see that it can short circuit and causing inattention and impulsivity. In the limbic system, it regulates emotions, and ADHD tends to result in restlessness, inattention, or emotional volatility. And also in the reticular activating system, the major relay between the brain's pathways seem to be disrupted. The DSM-5 has diagnosing criteria for ADHD. It defines the condition as a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development. Brain scans of patients with ADHD are giving us clues into the aberrations of neurosignaling. We think that deficits in the prefrontal cortex are manifested as poor problem solving and as impulsivity. Dysfunction of the noradrenergic receptors seem to affect how the brain identifies particular stimuli, the prefrontal cortex in particular. Dysfunction in the dopamine transmission seems to relate to transporters and receptors, and low dopamine decreases arousal, causing important signals to be seen as background noise rather than something to be focused on. So why don't we just supplement with high doses of norepinephrine and dopamine for patients who are suffering from ADHD? Well, other psychiatric conditions arise when we have too much dopamine and too much norepinephrine on board. So we don't want to push a patient over into another neuro or psychiatric illness by supplementing the neurotransmitters. The American Academy of Pediatrics has published clinical guidelines for treating children with ADHD. They recommend that children between the ages of 4 and 5 receive behavior therapy and start on methylphenidate. Between the ages of 6 and 11, they suggest behavioral therapy again, but also they open up the range of medications to all FDA-approved meds for ADHD, not just methylphenidate. The same goes for kids who are age 12 to 18. Behavior therapy is always recommended, and then 12 to 18-year-olds also have the full range available to them. So now that we're getting better at diagnosing ADHD in children, what does that mean for those adults that were diagnosed early in their lifetime? Well, we think that up to 66% of children with ADHD retain some symptoms into adulthood. It just manifests in different ways. So less hyperactivity, more inability to focus, complete tasks, and of course this can lead to difficulty in the home, in family functions, definitely at work, and in social relationships. Here's a summary of the drug treatment options we have available to us for treating ADHD. We have several different stimulants that include methylphenidate, dexmethylphenidate, a combination of amphetamine and dextroamphetamine, and a new medication called Lisdexamfetamine. On the non-stimulant side, we have Atomoxetine, which is a fairly new medication on the market, and some oldies but goodies called Guanfacine and Clonidine. So let's first tackle the stimulants for ADHD. The way they work, their mechanism of action, is that they inhibit reuptake of norepinephrine and dopamine into the presynaptic neurons. If you recall, dopamine and norepinephrine deficiencies seem to be at play with ADHD. So blocking the reuptake help those neurotransmitters be more available for signaling. By doing so, we stimulate the cerebral cortex and the subcortical structures. The medications in the stimulant category that we have available for ADHD differ in their affinity for the receptors and their action on dopamine. So we have several different ones, and they work all the same way, but with different action at different levels on the neurotransmitters involved. All of them, in general, have the same adverse effect profile. To some extent, they all cause diminished appetite, perhaps weight loss, some dysphoria, headache, abdominal pain, perhaps sleep disturbances, and in some cases, an increased heart rate. All of these stimulants we use for ADHD have a boxed warning applied to them, and this says that the CNS stimulants have a high potential for abuse and dependence. We have to assess the risk of a patient for abuse prior to prescribing or maintaining prescriptions for stimulants. This also box warning does mention that long-term abusive use can lead to tolerance and psychological dependence as well. As a class, the stimulants for ADHD have some serious but rare side effects that we want to be aware of. First of all, the cardiac effects. Some of these stimulants carry a box warning about sudden cardiac death, but the data is inconsistent, so just be wary of that and beware of using them in patients who have underlying cardiac issues or abnormalities. The other thing we need to be aware of is that stimulants can cause psychosis or psychotic episodes, even in people who have no other underlying mental illness. So we need to be careful about diagnosing people who have ADHD and really teasing out if they have any other psychotic tendency or psychosis episodes in their past. Benzedrine was the first stimulant developed in 1933. It really came about as a decongestant, and it was a racemic mixture of amphetamine, so both the D and the L isomers of that compound. From the 1940s on, it was highly abused, and it was removed from the market not long after. But we do have it in our culture as a reference to stimulants in general as bennies. The first stimulant we'll talk about on the market now is the mixed amphetamine salts. This is a mix of amphetamine and dextroamphetamine in the product. Brand names may be Adderall or Mideas. They come in extended release forms and immediate release forms. There is a product that is just amphetamine sulfate, so one of the salts that's in the mix. They've isolated that out, and the brand names of that could be Adzenys or Avakio. This one comes in extended and immediate release forms as well as an orally disintegrating tablet. Here's an example of the delivery form for Adderall XR, the extended release version of mixed amphetamine salts. In the capsule, there is a pulse delivery system. So we have an immediate release pellet inside the capsule, and then a delayed release pellet inside the capsule. So the patient who takes the Adderall XR gets an immediate pulse for immediate coverage of symptoms, as well as a longer term coverage in the delayed release pellets to last throughout the day. Dextroamphetamine is another product on the market. You may see it as Dexedrine, Zenzeti, or Procentra. It's the D isomer of amphetamine. It is the more potent isomer, and it has more affinity for those dopamine transporters and norepinephrine transporters. It's available extended release, immediate release, and in an oral solution. The FDA has approved the immediate release formulation for kids as young as 3 years old, although I think that it would be rare to treat a child that young for ADHD. The third stimulant we will talk about is methylphenidate. It causes release of norepi and dopamine from those presynaptic terminals. It also blocks the reuptake, so more of those transmitters are available for action. It comes in a dual phase dosage form because we found that the flat dosing isn't really effective. People develop tolerance to it pretty easily. This is what a methylphenidate extended release tablet looks like. The brand name of this one is Concerta. It has, similar to the pulse dosing effect that we had before, in that it delivers immediate and extended release versions of the drug throughout the day. This one has a capsule with several different compartments in it. The drug compartment 1 releases over a shorter period of time, like an immediate release, and then the drug compartment 2 is of the longer term extended release version where it is slower to release. Water seeps into the capsule into this push compartment, and it will fill up the push compartment and push the drug out through a port in the capsule. There's a special dosage form of methylphenidate called Jornay PM. It's relatively new on the market, and it was released specifically for kids who need coverage for early morning ADHD symptoms and then throughout the next day. It's taken in the PM, in the evening time, and you'll notice that it stays around here in the hours that it is taken from nighttime when it's taken here till about 8 hours later, and then the drug starts to peak in the system and then slowly be released. Compare that to the immediate release version of methylphenidate, where the moment it is taken, drug levels increase and then decrease. This particular dosage form is really good for kids who can take a medication at night and then have all day coverage, especially in the morning the next day. Methylphenidate has a lot of brand names. The ones you might be more familiar with are Ritalin, Concerta, and Methylin, but they also come in others. The dosage forms are varieties as well: extended release oral solutions, even orally disintegrating tablets, chewables, and even a transdermal patch. This one, if you recall, is approved for all age groups of ADHD sufferers. So I think that a lot of technology and research has gone into developing kid-friendly dosage forms for various age groups. There's also a variety of methylphenidate that is just Dexmethylphenidate, so just another iteration of that chemical entity. It works the exact same way as methylphenidate. The only brand name of this particular drug, Dexmethylphenidate, is Focalin, and the extended release version of Focalin XR. The Dex form of methylphenidate is 2 times as potent as methylphenidate, so it was just another product that was isolated for the particular isomer that is more potent and put into a drug formulation. This one has a capsule form that can be sprinkled on food if necessary. Here is what the Focalin or Dexmethylphenidate extended release coating looks like. Inside the capsule are small pellets, and those pellets have several layers. So there's a protective coating, several layers that release the drug over a period of time, both immediate and extended. And in the center, I suspect there is a yummy chocolate nougat. Lisdexamfetamine is yet another iteration of dexamphetamine. It was created by a different company, and they have branded it as Vyvanse. It works in exactly the same way. It's just a prodrug of dextroamphetamine. Studies of this drug have shown that it has a lower abuse potential than the other stimulants, so it has that going for it. It provides more consistent levels and slower uptake into the bloodstream, and that is probably why it is lower on the abuse potential scale. Now let's talk about the first non-stimulant that is approved for treating ADHD. That is Atomoxetine, or brand name Strattera. It works Similarly to the stimulants, it inhibits reuptake of norepinephrine, but it doesn't have any other activity on other neurotransmitters like dopamine. Simply works on norepinephrine. There is a box warning applied to atomoxetine about increased risk of suicidal ideation in children and adolescents. Adverse effects are fairly tolerable for atomoxetine: drowsiness, insomnia, GI upset, but most patients say that these resolve after a period of adjustment. There are rare cases of liver injury associated with atomoxetine, and we should use caution in patients who have cardiac structural abnormalities because of its action on norepi. Now, unlike the stimulants, it does have a slow onset of action. Think of this one more along the lines of like a antidepressant. It takes 2 to 4 weeks to get a effect for ADHD symptoms for atomoxetine. Compare that to stimulants that really begin working within 1 hour with the immediate release forms. Atomoxetine also has a weight-based dosing. If the patient is under 70 kilograms, generally we think of those as children or petite adults, we go for a more weight-based approach. For adults or anyone over 70 kilograms, we go for straight dosing of 40 milligrams a day. In February 2019, atomoxetine became the first drug for ADHD that had applied guidelines for pharmacogenomic dosing. So if we know the patient's status as a 2D6 metabolizer, that changes how we dose atomoxetine. You don't have to remember the activity scores and genotypes, but this is just a reminder for those of you who are interested in PGX. The drug labeling now includes guidelines on how to dose patients who may be in the ultra-rapid metabolizer category down to the poor metabolizer category. It gives different dosing strategies for these varieties of people you might encounter. It's always good to know the pharmacogenomic status of a patient when starting atomoxetine. If you don't have it, it's fine. Straight dosing is usually fine, but if you do have it, it is an actionable item. Clonidine is an old medication, and it was found to have some action in patients with ADHD, specifically those with aggressive behavior. It stimulates alpha-2 adrenergic receptors in the brainstem and therefore results in reduced norepinephrine release. The brand name for the ADHD extended release variety is Capve. But like all other alpha-adrenergic stimulants, we know that drowsiness, bradycardia, and hypotension, as well as dry mouth, are the common adverse effects. Guanfacine is yet another alpha-2 agonist, and its brand name is Intuniv. It's an extended release version as well. Works exactly the same way as Clonidine, good for ADHD patients with aggressive behavior, and it has these same adverse effects. There are a handful of drugs that have been used off-label, either as single treatment or more likely adjunct treatment for ADHD, and I've listed them here. All but one are antidepressants. The only one that isn't is modafinil. It is a CNS stimulant. We have a few tricyclic antidepressants on this list, as well as a dopamine norepinephrine reuptake inhibitor in the bupropion, and then an old MAOI inhibitor. If you recall from the review of antidepressants, I never recommend using MAOI inhibitors because of their side effect profile, dietary restrictions, and their drug-drug interactions. Now that we've reviewed the medications used to treat ADHD, let's talk a moment about other considerations to consider before writing the prescription. First, of course, we need to consider the patient's comorbidities. If the patient has high blood pressure or something that affects the cardiovascular system, a stimulant medication will only exacerbate those conditions. Other mental health disorders like bipolar disorder, severe depression, anxiety, schizophrenia, those can be severely aggravated by stimulant medications. So we need to make sure we have a proper diagnosis of any other conditions. When we do begin therapy, we should always start at the lowest dose recommended and then slowly titrate up to an effective dose. We should monitor the patient frequently, asking about symptoms and side effects, and then always assessing for signs of abuse or misuse of a medication. In general, children and adolescents should be treated first with methylphenidate. That is the drug of choice and what most organizations publish in their guidelines as the recommended starting medication. The dosage form and the dose can be altered quite a bit based on the patient's need for focus and activity. And if possible, the dosage form selected should cover as much of the morning time as possible if that's when the child is at school. For adults, a drug of choice used to be mixed amphetamine salts, but with the approval of Atomoxetine, I believe non-stimulants are going to become the drugs of choice. With their absence of abuse potential and their lower side effect profile, I believe more non-stimulant ADHD medications will be approved in the coming years. When a patient is on an ADHD medication, we should monitor their weight and appetite, as well as heart rate and blood pressure. That should be done every 3 to 6 months. And every follow-up, the patient should review a sleep diary to make sure that their sleep is not being disrupted by a stimulant. They should review a symptom diary with you to make sure that the dosage form and dose is effective for them. And for atomoxetine, we should check liver function as well. Let's look at 2 patients and select a treatment plan for both of them. Here in case 1, we have Tony. He's a 42-year-old male who presents as a walk-in to your clinic. He reports difficulty focusing on his work as a financial analyst. He's increasingly missing important details in his client accounts, and he says his boss has censured him for interrupting meetings and missing deadlines. He says he was diagnosed with ADHD as a teen and would like to restart his medication. What other objective information would you like to have about Tony? What subjective information would you need? And what tools do we have to confirm his diagnosis? Certainly some objective information that would be helpful is his cardiovascular health. We need to check that his blood pressure and his heart rate is normal before we consider putting him back on a stimulant. There are tools that we can use to assess his diagnosis of ADHD. Any one of those diagnostic tools that are published by reputable organizations can be used to test the patient and diagnose him properly. Some subjective information we would like to have is when his symptoms are worse, perhaps a time of day, what makes it better or worse, and we want to know what his goal of therapy is. So after reviewing his past medical records, his physician, you or another provider, has written him a prescription for Adderall, 5 milligrams by mouth twice daily. What patient education would you provide to Tony? And what monitoring will you perform when he sees you again? You should inform Tony about these side effects and the expectations of therapy, when he should feel better and when to call you if he is feeling something other than what's expected. You should ask him what twice a day means to him, because our version as providers may be every 12 hours. It may, in this case, be morning and mid-afternoon for a stimulant product for ADHD. We need to be very specific with Tony about when he is supposed to take his medications. As for monitoring, we should monitor his blood pressure, his weight, his sleep diary, his symptom diary, and anything else that you would want to discuss with Tony that should be in the monitoring plan. A month later, Tony returns for his follow-up appointment. He reports he's noted improved symptoms at work with his work performance. However, he says in the late afternoon he begins to lose a little focus. He asks if he should take his evening dose earlier or perhaps add a third mid-afternoon dose. How do you advise Tony, and what do you suggest for any medication changes? This gets to the point about when the second dose is being taken by Tony. It sounds like he's taking it in the evening, and that would explain why in the late afternoon his morning dose has fallen off in efficacy. So one suggestion would be to move his evening dose to an earlier time, perhaps mid-afternoon to early afternoon. It is possible we could add a third dose in the mid-afternoon if necessary, but at this point, moving the later dose to an earlier time seems more reasonable. Our second case is about RJ. He is a 10-year-old male who presents with his mother to your clinic. He's been on the following medication for 3 months: methylphenidate, 4 milligrams by mouth 3 times a day. His mother says his focus and grades have improved since beginning the drug, but he struggles during his morning routine. RJ says he doesn't like having to go to visit the school nurse every day to take his midday dose. What objective and subjective information would you like from RJ and his mom? And what do you suggest for his medication regimen? We definitely want to address his concern about taking a midday dose. It certainly could serve to single him out as someone who needs to take medication, and it is disrupting his daily routine. The mom's concern about his medication not being effective first thing in the morning is certainly something we need to address as well. So after consulting the patient and his mother, his medication is changed to Jornay PM, 20 milligrams POQD in the evening. After he's been on this medication for a month, his mother reports that the mornings have been much improved and he's able to focus at school. However, she notices that RJ sometimes wakes up around 3 or 4 a.m. and can't fall back to sleep. What questions do you want to ask RJ and his mom? Do you make any changes to his regimen at this time? Well, again, we haven't defined what in the evening means for RJ's evening dose of his new medication. If RJ is taking his medication at 6 p.m. in the evening, then it is very likely that the drug starts to peak in the bloodstream earlier in the morning than is ideal. So one suggestion would be to move the dose to bedtime, and that would ensure that the 8-hour latency period that occurs with this particular drug will occur during the nighttime while RJ is asleep, and then the drug will start to peak when he wakes up. We wouldn't want to change his medication at this point because I don't think that his new medicine has been optimized, and we can still make small adjustments to make sure his drug therapy works for him. Let's revisit the patient from case 1, Tony. It's 6 months later. He's returned to the clinic for a checkup. He says he's been off his ADHD meds for 4 months now, so he only took them for 2 months. He says he's had a rough couple of months, getting 2 DUIs in as many months. He says he's been drinking a lot to deal with his poor work performance and would like to restart his Adderall. So what do you recommend for Tony now? Well, certainly Tony has a lot of issues that we need to address. It sounds like he may have a drinking problem since he's self-medicating with alcohol. It would be good to know why he stopped taking his Adderall after only 2 months and then started self-medicating. Clearly, the alcohol is a problem since he's gotten 2 DUIs in 2 months. And adding a stimulant like the Adderall back to a person who's struggling with a substance abuse disorder is not a good idea. I would suggest that Tony be referred to a 12-step program or possibly a therapy group for substance abuse, perhaps see an addictionologist, but treating the ADHD with Adderall at this time is not recommended. We could argue for adding a non-stimulant, but still I think there are more pressing issues to address with Tony before we address ADHD. Thank you for joining me on this review of the medications used to treat ADHD. I am Dr. Amer Cann.